All right. Well, good afternoon, everyone. We'd like to welcome you all to this first look into findings from the Adult Cohort Learning Hub. We do want you all to know that this Learning Hub was curated specifically for our representatives at the request of the National Community Engagement Group's co-chairs. This webinar is unique, but we do have representatives joining, and we also have a representative who contributed to this paper and the work that went into producing it here on the webinar. And so we're happy to have Lisa join us as she can. Here is the agenda, and I am going to introduce our lovely speakers. So Dr. Andrea Folks is the contact PI for the RECOVER Data Resource Corps. In this role, she oversees data collection, statistical analysis, and interpretation of findings for the RECOVER initiative. She's also the Director of Biostatistics at Massachusetts General Hospital, a professor of medicine at Harvard Medical School, and a professor in the Department of Biostatistics at Harvard School of Public Health. Next, we have Dr. Tanayot Tawitai. He completed his PhD in biostatistics at the Harvard T.H. Chan School of Public Health before joining the faculty of the biostatistics group at Massachusetts General Hospital, where he serves as an instructor and the Associate Director of Biostatistics Research and Engagement. He is also an instructor at Harvard Medical School and the Harvard T. Chan School of Public Health. And lastly, he is the lead statistician in the Data Resource Corps at Mass General for RECOVER. All right, so next we have Dr. Upi Singh. She's an infectious disease physician and chief of the Division of Infectious Diseases at Stanford University School of Medicine. Dr. Singh is a physician scientist with over 30 years of NIH-funded research experience. And since March 2020, Dr. Singh has been involved in all aspects of COVID research and clinical care, including developing and leading clinical trials to identify treatments for COVID, establishing an infusion center to provide treatment and prevention medications to patients, and developing a long COVID clinic. Dr. Singh has also been involved in efforts to better understand long COVID with her involvement in the RECOVER initiative. And then we have Dr. Sairam Parthasarathi, who is a professor of medicine at the University of Arizona and an Adult Hub multi-PI for the RECOVER initiative. He is a researcher and a practicing physician in pulmonary critical care and sleep medicine. I'd like to say a big welcome to our speakers. And with that, I am going to give the floor to our speakers for their presentation.
Thank you so much. It's really a pleasure to be here. I'm going to begin and then to give an overview of some of the design aspects of the adult cohort study. And I'm here along with my colleague, Dr. Tanayut Tawitai from Mass General Hospital on behalf of the RECOVER Consortium authors and collaborators. I'll first give a brief motivation and overview of the RECOVER Adult Study Design, and then Dr. Tawitai will present the methodology we applied and some of the more significant findings. Finally, we will wrap up with a summary of the limitations, significance, and next steps for this research. So the analysis we are presenting today was based on survey data collected on just under 10,000 RECOVER adult participants, including approximately 8,600 infected and 1,100 uninfected individuals. The principal goal was to derive an approach to identify adults with long COVID based on self-reported symptoms. That is, we aim to leverage the available information on the full array of symptoms reported by each of the 10,000 RECOVER participants, both infected and uninfected, to arrive at what we have been calling a working definition of long COVID. The term working definition is important here because it emphasizes two complementary aspects of this work. First, the findings present a significant step scientifically in that they provide a rubric or rule for researchers to identify individuals with long COVID. This first step is essential for characterizing the different subgroups of long COVID, that is, the different manifestations of long COVID, for evaluating potential risk factors, investigating mechanisms of disease, and ultimately developing and evaluating interventions. Secondly, the term working in working definition is used as the findings provide a framework that can and will be further refined through the integration of data on clinical and subclinical assessments, including laboratory tests and imaging studies. Further analysis that integrates data across these different realms to refine and update the definition of long COVID is a crucial next step. And importantly, based on the findings that you will hear from Dr. Tawitai, we now have the groundwork or framework for doing this integration and ultimately arriving at a more discriminating, inclusive, and precise definition. So on this slide, you have a view of some of the important features of the RECOVER Adult study. In this visualization, each line represents a person, and the x-axis, that is the one at the bottom, horizontally shown, is the time from initial infection or a negative test for SARS-CoV-2. One important thing to note here is that infected participants in RECOVER did not need to have a positive PCR test to be classified as infected. Rather, they needed to meet the WHO definition of probable, suspected, or confirmed SARS-CoV-2 infection. And as a reminder, RECOVER Adult is an observational prospective cohort study, which that means that participants answered survey questions and had checkups and tests at regular intervals over time, but they did not receive any treatments or interventions as part of the study. In this figure, the shaded rectangles are enrollment visits. That's the first visit in the RECOVER study. And the ovals represent follow-up visits, which occurred approximately every 3 months after enrollment. As indicated on the left-hand side, there were 2 distinct cohorts: the acute cohort, which included participants with an enrollment visit, again, the shaded rectangles, during the acute phase of the infection, and that's defined as within 30 days of either infection or a negative test. And the post-acute cohort, which included participants enrolled during the chronic phase, that is more than 30 days after the date of infection or negative test. As depicted in this figure, post-acute cohort participants could enroll during any visit month, and enrollments ranged from visit month 0 to visit month 12 or later. Both the acute and post-acute cohorts included infected participants as well as uninfected participants. And the infected participants here were critically important as they served as contemporaneous comparator groups. The acute cohort made up about a quarter of the full cohort overall, and there was information on about 8 infected participants for every 1 uninfected participant in the study. Some important differences between the acute and post-acute cohorts are important to highlight, as these differences were present by design and help put some of the findings in context. So first, the post-acute cohort includes participants who were infected both before and after the time that the Omicron variant became dominant in the United States. That is, before and after December 1st, 2021. The acute cohort, on the other hand, included almost exclusively participants who were infected after the Omicron variant became dominant. And that's purely due to the timing of the initiation of the study. A second important feature to note is that RECOVER enrollment began after vaccines had become widely available. As a result, the acute cohort participants were largely fully vaccinated at the time of enrollment. The post-acute cohort, on the other hand, included participants who were vaccinated at the time of infection, as well as those who were not vaccinated at the time of infection. In both cohorts, the majority, that is about 90% of participants who were first infected when the Omicron variant was dominant, were also fully vaccinated at the time of this infection. Ongoing data collection for the RECOVER Adult Cohort includes demographic data, self-reported symptoms as shown on this slide, as well as social determinants of health, laboratory tests, clinical assessments, and clinical histories, including acute phase treatments and existing and new onset comorbidities. Select participants also receive additional tests and procedures, including, for example, the 6-minute walk test, chest CTs, renal ultrasounds, vision tests, and pulmonary function tests. The data used for this first analysis was limited to 44 self-reported symptoms, as you see here, spanning multiple organ systems, and we also used associated severity measures. Data on pre-existing comorbidities and demographics at the time of enrollment or infection, including age, sex assigned at birth, race and ethnicity, viral variant, and vaccination status were also considered. Finally, in terms of the design, the initial analyses that we're discussing here focused on a single time point per person that occurred at least 6 months after initial infection. That means for acute cohort participants, symptom reported at the 6-month visit, that is at the second follow-up visit, were used in the analysis. But for participants in the post-acute cohort, the first visit at 6 months or later was used. So for example, if a participant enrolled at 3 months after infection, that their symptoms at the first follow-up visit were used. While if a participant enrolled at 12 months after infection, then their enrollment symptoms were used. So I'm going to hand it over now to Dr. Tawitai, who's going to describe a bit more about the approach.
Thank you, Dr. Folks. So I'm going to talk a little bit about the approach that we took in this paper. So the goal of this analysis was to, develop a definition for long COVID by finding combinations of symptoms that we can use to identify people with long COVID. And so the way that we did this was to identify combinations of persisting symptoms, which were present 6 months or more after an individual's index date. And we focused on symptoms that were different between people with and without a history of COVID. So why does comparing infected participants with uninfected participants help us figure out what defines long COVID? Well, any differences that we detect between these two groups, infected versus uninfected, are going to be the same as the differences between long COVID positive people and long COVID negative people. And therefore, that will inform our definition of long COVID. So just providing an analytic overview of the approach. So there were 44 symptoms, as Dr. Folk showed in the previous slide, that we considered in the analysis. 37 of those 44 were present in at least 2.5% of the RECOVER study population. And these 37 were the ones that were included in all subsequent analyses. So given the really large number of symptoms that we were considering at the same time, we had to use sophisticated statistical techniques to identify which symptoms were the best at differentiating or separating infected from uninfected participants. And so once we've identified this shorter list of symptoms, we also then calculated here in step 2, we calculated symptom scores. And the higher a symptom score is, the more useful it is at separating infected from uninfected participants. And finally, a person's overall long COVID score is calculated by adding up the individual symptom scores for each symptom a participant has. So we calculated the overall long COVID score for all participants in the study, including uninfected participants. Then an optimal or best score cutoff was determined for identifying participants with long COVID in a way that's as inclusive as possible, while limiting the number of uninfected participants who are incorrectly labeled as long COVID positive. So I'm going to talk now about some results from the paper. So there were a total of 9,764 participants who met the study criteria. Overall, 71% of them were female, 16% were Hispanic or Latino, and 15% were non-Hispanic Black. The median or also the average age of participants overall was 47 years. Of the participants who were included in the study, 55% were fully vaccinated before infection, and 41% had their first infection pre-Omicron, so before December 1st, 2021. So that's just a summary of who's in the study. So here we're looking at the symptom score table. So in individual symptom analyses, all 37 symptoms that we looked at that had a frequency of 2.5% or greater overall were more common in infected than uninfected participants. And so this table here shows the 13 symptoms that we identified that were the best at separating infected from uninfected participants. And the symptoms here are ordered by decreasing score. When we assigned scores, one of them was rounded to 0. So there's actually 12 symptoms that correspond and contribute to the overall long COVID score. And so I wanted to highlight a couple of these scores here. So one of them that has a very high score of 7 is post-exertional malaise, which is defined as symptoms that are worse even after minor physical or mental effort, and also brain fog, which is defined as problems thinking or concentrating, which received a score of 3. And so there were also many other symptoms. There were some of these symptoms that are included in this table, such as brain fog, chest pain, and fatigue, that required additional severity criteria, which means that participants who indicated that they had one of those symptoms also had to answer some follow-up questions saying that their symptom was of moderate severity, meaning it was like moderately bad or worse, in order to have their symptom counted in the analysis. And so with this scoring table, an individual's overall long COVID score is calculated by adding up the scores for each symptom that a participant has. So for example, if somebody is experiencing loss of smell or taste, chronic cough, and brain fog, and none of the other symptoms that are in the table, then their score would be 8 plus 4 plus 3 for a total score of 15. So someone who has those 3 symptoms, but nothing else in this table would have a score of 15. Here we're looking at the identification of a cutoff rule. So the cutoff for long COVID was selected as 12, meaning that participants who had an overall score of 12 or above were classified as long COVID positive. And all others who had scores of lower than 12 were classified as long COVID unspecified or indeterminate or long COVID unknown, meaning that they don't meet the symptom-based criteria, but we don't want to rule out long COVID since they might have other conditions related to long COVID that may not have resulted in severe enough symptoms to meet the scoring cutoff. I want to point out that someone does not need to have all 12 symptoms to meet the scoring threshold of 12. As we saw in the example that I just went through, someone with 3 symptoms was able to have a score of 15, thus meeting the long COVID positive cutoff. So you don't need to have all 12. There were also some other symptoms that were highly correlated with the symptoms included in the score, which are listed here, including dry mouth, amongst others. The use of 12 symptoms for the score in no way is meant to minimize the importance of the many other symptoms people experience and shouldn't make any of them less real, debilitating, common, important, or worthy of scientific research and medical attention. So this figure shows how frequent or how common each of the 12 symptoms are among participants who were classified as long COVID positive. So if we look at all the people in the study who had a score of 12 or above, how common were these 12 symptoms? And so the symptom with the highest score, loss of or change in smell or taste, was not the most frequent symptom that we observed. The most common two were post-exertional malaise and fatigue. There were some symptoms here that are quite rare, but are still important symptoms for defining long COVID because they're very good at separating infected from uninfected participants in the RECOVER study population. So some results overall, just summarizing the rates of long COVID in the overall RECOVER population and the adult cohort. So in the whole adult cohort, 21% of infected participants were classified as long COVID positive. But this is not a population-based estimate, And the conclusion should not be that 21% of people who get COVID develop long COVID. And that's because RECOVER is not directly representative of the US population, since there are some people who enrolled into RECOVER because they were already experiencing long COVID symptoms. So we don't want to extrapolate from this 21% number. But if we only look at infected participants who were recruited within 30 days of their first infection, the acute cohort that Dr. Folks was describing, then this gets us at a little bit of a closer estimate of the rate of long COVID amongst people who are infected, because these individuals enrolled within 30 days of being infected. So it's a better estimate of this quantity. And so we found that 10% were classified as long COVID positive if we look at just the acute cohort. And also we restrict to people who were infected after December 1st, 2021, which is the Omicron cohort. And so the reason why we mostly are looking at participants in the Omicron cohort is because enrollment only started in October of 2021. So anyone who enrolled in the study in the last 2 years, where enrollment was within 30 days of infection, would meet this criteria. So most of the acute cohort is Omicron. We also had some results related to vaccinations and reinfection. And so the rate of long COVID was higher among people who were not fully vaccinated if we're looking at the acute Omicron cohort, which is that cohort that I just described. And so among fully vaccinated participants in this group, in the acute Omicron cohort, the rate was 9.7%. And this is compared to the rate of 17% among the unvaccinated individuals within this cohort. Also, in the Omicron cohorts, the rate of long COVID was higher among people who had a reinfection between their first infection and the study visit that was used in the analysis. The rate of long COVID was also higher among people whose first infection was pre-Omicron, so before December 1st, 2021, than for people whose first infection was on or after December 1st, 2021. We also found some interesting findings related to potential subgroups of long COVID. So we used some statistical methods to see whether we could group the participants who were long COVID positive into subgroups based on their 12 long COVID symptoms. And we found 4 subgroups, each of which had about 1/4 of the total long COVID participants. In one subgroup, the main symptom that they had was loss of smell or taste. In the second group, there was very little loss of smell or taste, but the rates of post-exertional malaise and fatigue were very high. In the third subgroup, we again found very little loss of smell or taste, but found that the rates of brain fog, post-exertional malaise, and fatigue were all very high. And then in the fourth subgroup, we found that the rates for practically all of the 12 long COVID symptoms were very high. And it appeared that this subgroup had the worst version of long COVID. Among people with long COVID, we also found that people who were unvaccinated were more likely to be in this fourth subgroup, and that people who had reinfections were also more likely to be in this fourth, most severe subgroup. So finally, I just have some conclusions and limitations of the study. Next slide. Thanks. So we reported some early findings from a large prospective cohort study where we learned from patient-reported symptoms. We developed a straightforward, data-driven scoring framework to classify long COVID as a condition unique to COVID-19. Many of the symptoms here that we identified overlap with those of other conditions that people have long suspected to be associated with long COVID, including things like dysautonomia and myalgic encephalomyelitis chronic fatigue syndrome, or MECFS. We also identified 4 distinct subgroups of long COVID, finding one subgroup whose hallmark symptom appeared to be loss of or change in smell or taste with few other symptoms, and then a very severe subgroup which had many different symptoms, suggesting that maybe long COVID is a syndrome of syndromes rather than one disease that looks the same way for everyone. Additional subgroups of long COVID may also be identified when biomarkers and other clinical findings are incorporated into this working definition. And finally, we observed that being unvaccinated and being reinfected were all associated with long COVID. These are preliminary findings that are going to be the subject of upcoming manuscripts, where we dive a bit deeper into risk factors associated with long COVID. Vaccination is really tricky and complex, so in these analyses, we didn't account for the time between when you were vaccinated and when you were infected or the effect of boosters. So I'll hand it back now to Dr. Folks to comment on the significance of the study and some next steps.
Thank you, Dr. Tawitai. Before moving to our panel discussion and question and answers, I just want to highlight a few of the important attributes and the significance of this study. First, it is a prospective cohort study that followed many individuals from the time of first infection. In this subgroup, whom we've been calling the acute cohort, there is less selection bias than studies that enroll individuals several months after infection, individuals who may be enrolling because they are experiencing symptoms of long COVID. The RECOVER study also included a contemporaneous comparator group of uninfected individuals because many of the symptoms of long COVID are experienced by individuals with and without a history of SARS-CoV-2 infection. It is really important to include a comparator group to parse those symptoms that best distinguish these two groups. In RECOVER, the survey instruments were designed by many different stakeholders, including patient and community representatives, many of whom are on the call today, clinical scientists, epidemiologists, and biostatisticians. As a result, the RECOVER study included symptom questions that did not appear in earlier studies, which is one notable symptom identified was post-exertional malaise. It's also important to note that the RECOVER study was based on self-reported symptoms, which is different than electronic health record or EHR data. EHR data can be helpful in identifying individuals who reported a symptom, but if a symptom is not recorded in the electronic health records, it's not clear to researchers whether the individual doesn't have that symptom or simply didn't have the opportunity to report it. For this reason, self-reported symptoms are considered more accurate. As we heard in the RECOVER study, 1 in 10 of acute cohort participants with a first infection after Omicron became the dominant strain, the majority of whom were vaccinated, met the symptom threshold for long COVID. However, the score cannot tell us if somebody does not have long COVID. That is, if someone doesn't meet the score threshold, they may very well still have long COVID. Further evaluation of clinical assessments and laboratory tests may reveal more participants who have long COVID. One of the more significant contributions of this work is that it provides a unifying framework for studying long COVID. That is, the proposed definition of long COVID takes an important step beyond consideration of each symptom individually. Rather, the definition integrates information across multiple symptoms simultaneously, taking into account if and how symptoms tend to occur together. By consolidating information on multiple symptoms, the approach that we took in the JAMA paper turns an important corner, providing a framework for identifying people with long COVID. And as such, it provides a critical launching point for investigations into the risk factors and mechanistic underpinnings of disease. In other words, by having a definition of long COVID, we can begin the pivotal next step of in-depth investigations into why some people get sick and experience the more severe manifestations of long COVID, while others do not. And ultimately, what are the pathways to recovery? In addition to further refining the definition of long COVID in adults, it is essential to independently consider pediatric populations and how long COVID manifests in children. At this stage, we do not know if long COVID is different in children, and a rigorous analysis of data from the RECOVER pediatric cohort is of paramount importance. Finally, fully understanding long COVID will inevitably require careful consideration of the longitudinal trajectories of individuals over time. We recognize that symptoms may come and go over time. We saw that in the JAMA paper, and that over time, individuals will be exposed to vaccinations, boosters, treatments, and repeat infections, not only to SARS-CoV-2, but other viruses as well. With all this in mind, further research will need to approach the complex interplay of all of these factors comprehensively. So we're going to move to the question and answer, but I do just want to take this opportunity to thank all of the participants enrolled in the RECOVER initiative, the National Community Engagement Group, and all patient, caregiver, and community representatives. So thank you. And I will hand this over now to Dr. Singh and Dr. Parthasarathi, who will be giving additional commentary.
Yeah, hi, everyone. Good afternoon. Thank you so much for joining us. I think that was a really great summary from Dr. Tawitai and Dr. Folks and Dr. Parthasarathi, and I thought we would just sort of go over some of the highlights once again. So again, I think it's been said, but it's worth repeating that people who score 12 or below may still have long COVID. And that's why that definition right now is called PASC indeterminate.
Yeah, that's right, Upi. I think along the same lines, it should be mentioned that this definition is not for clinical use or for determining disability ratings. This is a research definition in order to distinguish the infected from uninfected, and it should not be used for clinical diagnosis or determining disability ratings or for inclusion into clinical trials. Back to you, Ruby.
Yeah, so as we just said, the definition shouldn't be used for eligibility for clinical trials. I know that's a question and a concern for large numbers of the community. Our strong opinion is that the basis for clinical trials right now should be on the basis of a COVID infection or presumptive COVID infection, and then symptoms or organ dysfunction that's being addressed in a specific trial.
Yeah, and also I know these questions, will come. It should be stated that these 12 symptoms that were assigned these scores that both Tanyo and Andrea went over, they are not necessarily the most common. They are not necessarily the most troublesome. They're not the most burdensome of symptoms that patients experience. They are sort of the distinguishing or discriminating symptoms in the RECOVER cohort that, distinguish the people with true positive, past cases from the unspecified group. And when we say unspecified group, as was stated earlier, that doesn't mean that they don't have PASC or don't have long COVID. They could still have it. But in order for us to be able to identify who are clearly or slam dunk have, PASC, we need to use this particular threshold so that then we can identify what are some of the biomarkers that we can find in these people, so that then we can take those biomarkers and diagnostic tests and apply it to the people who currently are in the unspecified category, so that we can sift through them and identify who there truly has long COVID.
That's right. And so in addition to these 12 symptoms that we've discussed, there were another about 25 symptoms that were more common in individuals who were infected compared to those who were uninfected. And in fact, there even may be other symptoms that haven't been identified, since this is all based on patient-reported symptoms.
Yeah, and also the way in which these symptoms, cluster together, and I think it's an important takeaway, is that it can give us some better insight into why those symptoms actually sit together or more commonly associated with each other, which can actually provide insight as to why they develop the condition, as well as what are some of the potential treatment options that we have for them.
Yeah, and I think, as we talk to family members, friends, colleagues, members of the community, one of the questions always comes up is how can we prevent long COVID? And I think the data clearly show that vaccination was associated with reduced odds for long COVID. And I think it provides rationale for ongoing vaccinations and boosters to protect against other variants as ongoing aspects of the pandemic continue.
Yeah, and along those lines as well, I think the fact that people who had more infections or multiple hits, as people like to call it, or more virulent infection, like in the pre-Omicron, the Delta variant, and things of that nature, had a greater chance for developing or greater risk for developing long COVID or PASC. So that actually suggests that organ injury in terms of how individuals' organ systems, just lungs and heart, are affected, goes a long way in determining who is going to take longer time to heal, and therefore who's going to continue to have persistent symptoms, which we call long COVID or PASC. But that is not to, again, take away with other theories as to why people develop long COVID. And there are considerations that in some people, the virus may persist in them, called viral persistence, and autoimmunity, where their own immune system attacks their own body, as well as immune dysregulation, where their immune system is not functioning optimally, and it allows the virus to persist, or for other organs to not work well because of the immune dysfunction. So I would say that, from a clinical application or clinical standpoint, these would be some major takeaways. I think we can go back to the Q&A from the group and see what are some of the questions that we need to tackle. Back to you, Brittany.
All right. So just want to say thank you to our speakers for sharing this information so eloquently and yet so understandable for our audience, with our representatives that are present, in addition to community members and any clinicians that are also present. I also want to just set the stage for some rules of engagement. I want to ensure that we are treating everyone present and throughout the initiative with dignity. And then just want to make sure that we are respecting differing views, as we are all representing diverse backgrounds, cultures, education, and unique experiences. And just one more point of clarity is that for this Q&A session, we'll be focusing on the paper, in addition to the community impact resulting from this information contained in the paper. And with that, we're going to start with the questions that we received prior to the start of the webinar. So here we go. How can this information be better communicated to the general public and health practitioners so that they really help the public? And what are the next steps for clinical options given what we've learned?
I can start with that, and then maybe Dr. Parthasarathy can add. So I think this brings up, it's a great question. It brings up such an important topic. We can discuss science and what we've learned, but the real goal of our work is to spread the information as broadly as possible to reach as many patients, as many family members, as many providers, including members of the government, right, who are going to sort of help identify new ways forward in research and in therapies. So I think there's a lot of efforts. Certainly members of the phone call here now are involved in a local outreach at their local sites. And I think conferences such as this with NCAG are a great way as well to do that. I think another way that information is often spread, which has a little bit of an angle that can be a little harder sometimes, is media. And we know that this paper was picked up by a lot of media outlets. I think what I would say, though, to all of you who are a part of NCAG and are part of community engagement efforts, sometimes the media takes the tip of the iceberg and the soundbite, and that soundbite isn't complete. So I do think it's all of our jobs as healthcare providers, as scientists, as experts in the field, or as people who have family or friends with this disease, to spread the information and say, yep, this soundbite is the tip, but there's so much more. And I think that's going to, just have to come multifactorial ways to spread the word.
Yeah, Dr. Singh eloquently described how it should be communicated. And I think this is a very important question because too often research is done and it is published in a high impact paper, but it takes on an average 10 years for 17% of that research to actually benefit the people in the community. So this is a very important question and we take it very seriously. What I wanted to add, I don't want to repeat all those elements that Dr. Singh eloquently described. What I want to add is that it's incumbent upon us, the researchers that were part of the study, to become champions, to spread that in the community. And a couple of things that I just wanted to mention is Here in Arizona, for example, through a CDC-funded initiative, we are doing grand rounds, virtually to identify practitioners who are out there who are yearning to learn more about this condition, how to diagnose it, how to treat it, so that we are spreading that information. Some of that is similar to a format called Project Echo, where they can bring their difficult cases and without sharing any privacy or private or confidential information, they can actually learn from the experts as to how we would diagnose and manage those patients. And so other than that, we also have a warm line that is also CDC funded, where healthcare providers out in the public who out in the community, be it either in rural or urban areas, can call us and actually say, okay, I have a difficult patient I have here. I don't know if this is long COVID or not, and I don't know how to manage it. Within 24 hours, we call it a warm line because we can back them in 24 hours. So those are just a couple of examples. But I think the Agency of Health Research Quality, or otherwise called ARC for short, is creating centers of excellence, whose one of their main jobs is to help educate not only the practitioners, but also the communities that they live in broad swaths of the country, so that we can disseminate all the learnings that we have learned through this study. It's been a steep learning curve for us. Now we hold that valuable information. It takes time to write these papers and publish them, and a lot of people don't have time to read them. Our job is to get straight to the people, get it straight to the doctors, nurse practitioners, other advanced practitioners, as well as community health workers who are embedded in the community, to spread that word so that we can make sure that every human being benefits from what is essentially taxpayer dollars that comes back to benefit them, to answer those important questions that they have both for themselves and their families.
Great. Thank you so much, Dr. Singh and Dr. Sai. I think you hit some great points, and I really want to thank you for highlighting the importance of community health workers and their role in communicating this to the general public. So our next question asks, is there any data that leads to believe that the long COVID symptoms will eventually disappear, i.e. heart pounding, ear ringing, shortness of breath, etc.?
I can, I can take a stab at it, then I can ask Andrea and Taneo to jump in. But actually, even in this JAMA paper, in a subset of participants, it was noticed that compared to the 6-month visit, at the 9-month visit, there were about 32% of individuals who had the symptoms at 6 months who did not have it at 9 months. In other words, they went from being mass positive to the unspecified group. But then there were about 6% or so of people who at 6 months didn't have it. In other words, in some ways, where in the unspecified group, it didn't have a high enough score, but then they ended up in the group that actually had a score of 12 or above, suggesting that this condition waxes and wanes, but in general, there are more people going in the correct direction than people going in the wrong direction. I'm curious to see what Andrea and Taneo have to say.
I think I agree with you wholeheartedly that there's some data to suggest that there may be some form of recovery that we're seeing, but at this point it's very early to say for sure. So what is clear is that people are ebbing and flowing. So symptoms are coming and going and then coming back, unfortunately. So we really don't know yet if there are going to be individuals that experience a full recovery. One of the next really important steps for recovery is to begin looking at recovery. But we want to be really careful in doing that because we don't want to assume someone's recovered prematurely. There may be subclinical things going on with an individual that will eventually manifest in more severe disease. So we're being very cautious in defining recovery, but our next step now that we have a working definition of long COVID is to begin understanding better and defining what does it mean to recover from long COVID. So very much an ongoing and high priority area of research.
Yeah, and I was going to cite the same statistics that Dr. Parthasarathi did, and so I think some of the papers that we are, actively planning and thinking about are going to be looking at better understanding both the kind of natural history and natural progression of long COVID over time. And as was mentioned, RECOVER is not an interventional study, so there's not like a treatment or treatments that everybody is receiving, but we are learning and recording information about intervention that people may be receiving from other places. And so we're very interested in looking at understanding what we can learn about other interventions that people who are in RECOVER are receiving, and learning whether trying to figure out what questions we can answer from this cohort who has from which we're studying longitudinally. So we're looking into it and hope to have more answers in the future.
Absolutely. Thank you so much. Well, you all are quite, have some great foresight, because you actually already answered our next question, which asked, with someone suffering from long COVID, this seems to be an evolving disorder with symptoms that develop and then subside. And so you pretty much address that in addition to the question on treating such a disorder. And so since you've already proactively addressed this question, we're going to fast forward to the next one. So this also addresses symptoms somewhat. And it says, I have long COVID. I've had it for over a year, and I also have Down syndrome. I'm interested in finding out ways to recover and gain some energy back. Is that possible?
Yeah, I can start to answer that question. So first of all, thank you for sharing what's obviously been a very tough time and a tough compilation of things that have happened. I think at this point, unfortunately, there isn't a specific treatment for long COVID. That's obviously the work of our group as well as many other groups. What I would encourage, but I'd like to see what Dr. Parthasarathi said, I would encourage to make sure that all other health conditions are addressed and that you have good primary care or other providers who can make sure that any other medical conditions apart from long COVID are being well managed. And then I always think that one of the ways that we can sort of move forward is by participating in clinical studies if somebody's able to. And, if there are certain ones that align more with your symptoms and you're able to participate safely, I would encourage that. Keep in mind, clinical studies, there's no guarantee that the treatment that's being studied will be beneficial. But I do think there's a real need to answer, the questions of what can help, what will not help, really scientifically and rigorously. And so those would be my suggestions. But Sai may have other comments.
I think you answered it. The one thing I would say is that the NIH funded clinical trials are coming your way, and now would be a good time to actually look to see where your closest center is that would enable you to enroll as a participant. There are other studies that are ongoing right now, which are not part of the RECOVER clinical trials. And so it's also important for you to go to clinicaltrials.gov or clinicaltrials.gov to actually put in long COVID and see what are some of the studies that are available. I did want to echo what Upi said, is that all of these studies are being done for people such as yourself to bring treatment and cures. It is not that is the ultimate goal of the National Institutes of Health, is to find treatments and cures to bring it to you. But sometimes we need to understand the disease in order to be able to do that. But that's the number one importance.
All right. Thank you for providing those recommendations and insights. I'm going to segue over. I think we might have time for one or two questions that we've received during the webinar. And so that first one somewhat ties in. These are all tying in. Did you all have any participant in the study with Down syndrome or any other intellectual and developmental disabilities? Are we aware of that? And it might be something we have to get back to you on.
Yeah, it's a terrific question. I don't know offhand whether we have participants with Down syndrome in the study, but perhaps we can follow up with that.
Sure, we'll mark that and make sure we send that out in our follow-up correspondence. Okay, that brings us to the second question. With a title RECOVER for the study, are you looking at treatments and what works to recover? I also think this addresses other questions that some attendees may have.
Yeah, I think that's what Dr. Parthasarathi and others have been saying. So a number of different clinical trials are starting within the NIH RECOVER platform, and these trials will be looking at things, and I see some questions about viral persistence. You know, is there viral persistence and can we target that virus? Will that help? There's some clinical trials that will be starting to address issues with sleep that patients with long COVID often have, issues with brain fog, et cetera. So a number of clinical trials are on the way, and I'm very hopeful that we'll get great patient engagement and be able to get some good answers soon.
I'll just add to that and follow up on Dr. Tawitai's point about the information we're collecting on currently on treatments within RECOVER. There's challenges in observational data to look at treatments because people who take specific treatments may be different than individuals who don't have those treatments. So we have to be very careful within the context of a cohort study to evaluate the impact of specific medications. That said, there are some sophisticated statistical methods that can be used with a lot of care to make sure that there's not bias in our findings. In the context of the adult cohort, there were many different treatments collected. So that included steroids, antibiotics, anticoagulants, antivirals, and many, many more. We also provided participants with an open text box to indicate any specific treatments that they received over the course of participation in RECOVER. And we're in the process of starting to mine those data to identify if there's any other treatments that we're seeing that we can begin to evaluate. So as was mentioned, really the gold standard are the clinical trials. We do anticipate through RECOVER in the clinical trials that there will be developments with respect to effective treatments, but we are also looking at the observational data, looking at the treatments people have tried themselves and seeing if there's any signal in these data to suggest that a treatment may be effective.
Thank you very much for addressing that question. So we are almost out of time. And we want to thank everyone again for joining us for this Learning Hub. So I do want to just take a quick minute and say a big thank you to our speakers from the National Community Engagement Group. I know you all have been using our affectionate acronym NCEG, but for those who don't know, that's what it stands for. So I know I failed to introduce myself, but as a RECOVER community representative and also NCEG co-chair, we are very grateful to you all taking the time. I also want to say a special shout out and thank you to Lisa McCorkle for all of her involvement and assistance and for also representing the representatives as a whole. And lastly, just want to make a note to everyone who we weren't able to get to your questions. We will make a concerted effort to somehow address this in the follow-up correspondence as applicable to my previous statement on those questions that are coming in that are solely addressing A, the paper, and then B, the community impact as outlined in the paper. So with 1 minute left, thank you all again. And to the speakers, is there any last nugget that you want to add before we log off?
I guess I would just, echo the thanks for the patients, the participants, their family members, all the nurses and social workers and others who sort of helped launch this study. It is a true labor of love, and it takes a village. I've used a bunch of acronyms, but you get what I'm saying. It's a lot of work, but such important work, and it has to continue. I think that's just really the thing. We are sort of at the tip of the iceberg at the early stages of understanding this disease really deeply and really well. And so I know all of us on this call are engaged and excited to continue the work. And we do think, and hopefully that, patients and participants and social workers and others will help us in that mission. Thank you.
Thank you.
Go ahead.
Oh, I just wanted to say thank you for this opportunity, and thanks to all the participants for joining.
Thank you. I think you all have said it best. This is definitely still a learning experience. We're discovering new things every day. So just asking everyone to be patient with us. And again, this was such a great session, and you all providing the information in an understandable manner and highlighting some great aspects that we have learned thus far with RECOVER. Wishing everyone a great rest of your Tuesday and a great week. And we'll be in touch. And if you'd like to stay in touch, here is how you can keep in contact on the screen. Thank you so much and have a great day.